the Achilles, the man's weakness in their Achilles, amongst other weaknesses in men. That is one of the big weaknesses in men, not so much in women. And then understand the management of the injuries. Let's go, you're killing me with this, come on. Got a lot of material to go through. Okay, ankle sprain is a ligament tear. It's a partial tear. You don't say that necessarily to the patient on day one, because they get a bit frightened of that concept. But even a mild sprain, a grade 1 sprain, is a partial tear. It's just the extent and how long it's going to take to get better. So in grade ligament tears, do you know about that? Yep. Grade 1, grade 2, grade 3. Where a grade 3 is a complete rupture where the ligament is separated and there's a gap. But most sprains are just a grade 1 or grade 2 where there's been a partial tear. The ligament is stretched. To the naked eye, you wouldn't see it was torn, but at the microscopic level, the fibres are torn, even in a grade 1. Yeah. So there's a healing time that has to be respected, soft tissue healing, which is, we know, that's 6 weeks. The lateral ligaments are stretched in a forced inversion, and the ankle is less stable when it's in plantar flexion. So it's nearly always a plantar flexion and inversion. So the foot drops down into a hole, let's say into plantar flexion, and then it inverts. To really invert and get a complete tear, your foot has to be fully plantar flexed, so the talus is basically subluxed forward. Yeah? So the talocrural joint essentially dislocates if you have a grade 3 inversion tear. Yeah, that's a really bad one. In dorsiflexion, the ankle is stable, so it can't really tear. When it's locked into dorsiflexion, it's really difficult to roll your ankle into inversion. So dorsiflexion protects your ankle, yeah? It locks in. Now that happens when you step in a hole, step on an opponent's foot, land from a height with your foot a little bit plantar flexed and inverted. And if your ankle is a bit unstable already, it pretty much hangs in a bit of inversion. Yeah? So when you're in mid-air, your ankle is hanging in a little bit of inversion, you land, you roll your ankle again. Happens over and over again. Yeah? And you step in and then after a while it just happens, it just gives way and it becomes really unstable. You trip over a crack in the concrete or something like that. Alright. In soccer, your ankle can be forced into plantar flexion inversion by your opponent who's giving you a bad tackle. So that starts up and tackling you in a bad tackle way, or a fall onto the ankle. Yeah. Which ligament tears first? In plantar flexion and inversion, it'll always be the anterior talofibular ligament. That's the ligament that tears first. Then the capsule will tear, it starts to spread as you get more force. ATFL, anterior capsule, lateral capsule, then the calcaneofibular ligament, yeah, which is between the fibula and the calcaneus. And that spans 2 joints, if you think about it. It's spanning the talocrural joint and the subtalar joint. So when that one tears, you have an instability of 2 joints. It's a lot worse. And most of them, luckily most are isolated to the anterior talofibular ligament. Then if it gets even worse, it'll spread even more anteriorly and more posteriorly, yeah? And you get the posterior talofibular ligament, but that is rare. It's really rare. Maybe you can tear it if you really force your ankle into inversion and it's in neutral, or it's in a little bit of dorsiflexion, but it would take a lot of trauma, yeah? Oh, what does that say? Sometimes there's a hidden small fracture. The force can avulse a piece of bone. When the ligament tears, it pulls off a chip of bone. You can't always tell that straight away, but it's one of the reasons why the ankle won't respond in the expected way to the rehab. So it stays painful and stays swollen and stays stiff for longer than 6 weeks, and you're going, why? Well, actually there's a hidden fracture or a hidden injury. There's a really common hidden injury to the dome of the talus in basketball when you fall, when you land on another player's foot, or you land from a height, you jump over a fence or something and land, and you have that vertical height characteristic to the injury. You knock off a corner of the top of the talus, the dome of the talus. That's an osteochondral fracture. It's a hidden injury. It's hidden. But the clue is the mechanism of injury. Now, you don't have to x-ray everybody's ankle who's got a sprained ankle. There are rules that you can follow. If you work as a physiotherapist in emergency department, and a lot of physios now do work in emergency departments, and they see sprained ankles all day long, they have to decide which ones to x-ray and which ones not to, just to rehabilitate. There's this set of rules called the Ottawa rules to decide whether somebody needs an ankle x-ray or a foot x-ray. Have you heard of them? You're familiar with them? Good. You need to know them because they're very accurate. All right. Now, the rolled ankle or the sprained ankle. First of all, inversion more than eversion. The lateral ligaments are weaker, and there's the direction of the axis of the ankle joint isn't horizontal. It's at about 30 degrees. So the ankle naturally wants to go into inversion when it goes into plantar flexion. Also, the fibula, the tip of the fibula is a bit lower than the tip of the medial malleolus. Yeah? So there's a buttress to eversion, which is the lateral malleolus stops eversion, but there's nothing that much to stop inversion. Right? So there's some of the reasons why. The medial ligament, the deltoid ligament of the ankle, is a monster. It's really thick, really, really strong. To tear that, that's a massive amount of trauma. And if you rupture the medial ligament of the ankle, you're in a whole lot of trouble. That means there's been a massive amount of trauma. It's thick, it's in 2 layers, it's really strong. It's almost impossible to tear. It can tear with really, really massive trauma, and often the knee ligament tears at the same time, and often there's a fracture at the same time to tear the deltoid ligament. I'm finding that really hard to read, but you've got that in front of you, yeah? You can see? Anyway, I'll keep going. So that's down there on the left-hand side. Okay, here's the grades. Grade 1's a partial tear. You can think of it in 2 ways. It's how many ligaments are torn? Alright, a grade 1 is 1 ligament, a grade 2 is 2 ligaments, a grade 3 is 3 ligaments. Or you can think about in terms of the actual pathology. Is it partial tear, worse partial tear, or a complete rupture? So get those sort of concepts get used interchangeably in grading ankle ligament. But anyway, usually a grade 1 is a partial tear of ATFL. Yeah? And a grade 2 might be a total rupture of ATFL and a partial tear of the CFL. Yeah? And then grade 3 might be all 3 might be torn. Yeah? And then the timing-wise, there's a 2-week, 4-week, 6-week sort of scenario. And that's not how long it takes to heal. That just takes how long it takes for the pain to go away and for someone to start to move a little bit normally. That doesn't mean they're right. That doesn't mean they're healed. This is a common sort of misconception, yeah? There's a tricky one called, I talked about the medial ligament. There's another tricky one called a high ankle sprain. Who's heard of that? Yeah? It's a very tricky one. What it is an external rotation injury. So in football or soccer, let's say, the foot is stuck in the ground, studs are in the ground and it's locked in, and another player falls across that player's leg that way, or tackles them this way. Foot stuck. You know how the talus is like a block, like a box, like a matchbox or whatever? As it turns, it separates the syndesmosis. So you've got that external rotation force, splits the syndesmosis vertically. So it tears, it basically destroys your ankle joint because you've got a torn syndesmosis, you haven't got that stability in your ankle joint anymore. So it's a very disabling injury. The third thing that happens, as that person gets forced in like that, the medial ligament of the knee can be torn as well. or an ACL of the knee. So it's a sort of unhappy triad of injury, the three in a row. It's very, very traumatic. The injury will spread to the inferior tibiofibular joint and split the syndesmosis, and you can have a fracture higher up also in the fibula, and that's called a Mason nerve fracture. So in a minute we'll discuss the rules are about where the tenderness is in the fibula and the ability to walk. Those ones need an X-ray, but the X-ray has to be done high up in here because the fractures are right up here at the top. So understanding the pathomechanics will help you decide. Can you see that? All right, that's Totsi, and his toe is stuck in the turf. His whole leg is externally rotated, and has a catastrophic ankle injury. He was able to recover from the injury and play the next season. That's a high ankle sprain. There's special tests for that. All right, now, this is really important. The healing time is not the same as the recovery time. Like you can, in the context of leg sport, you can push a player to recover from an ankle injury in a week. Yeah, you can. If you're an AFL player with a grade 1 ankle sprain, you're having treatment 24/7. You're getting physio on it all day long. You're icing it at night when you're at home, and you're having very intense treatment to be able to recover from that injury, to be able to play the next week. That doesn't mean the ankle's healed, but it means you can do that, and if that player is tough enough and motivated enough, it can play with a sprained ankle. It'll be taped up, so it'll be completely, virtually immobilised and protected. But there's a price to be paid for doing that. The price to be paid is that joint is compromised probably for the rest of that player's life. So it'll stay swollen, it'll stay painful, and it'll be stiff for weeks and weeks and weeks and weeks, yeah? Because you've gone back and played on it before it's healed. For the other extreme is a person who doesn't do any sport or is maybe a social athlete. Your ideal scenario is this. A grade 1, you can get back a minimum of 2 weeks. Still takes 6 weeks plus to heal. But functionally, you can get somebody back within 2 to 4 weeks with good physio treatment. Grade 2 is worse. It takes longer, and it's going to take 4 to 6 weeks to recover. You can get them back in 2 weeks or 3 weeks if you push hard enough, but that ankle's going to stay swollen, painful, and sore for a long time. What happens is when you go back too early, it becomes inflamed, and you get this thing called a synovitis around the ankle. All the soft tissue around the ankle, if you looked at it, would be red hot, it would be swollen, and it seeps fluid, and it's always swollen, right? So that's what happens. A grade 3 is much worse, so you've got a rupture. It can still heal. A complete rupture can still heal. The body's got a very strong tendency to bring the ends of it. Remember, when it ruptures, it doesn't like snap in the middle. It just stretches out a bit like a horse's tail, yeah? So there's still ends of it in contact, and the body has a strong ability to knit all that back up. But a badly sprained or partial tear ligament is stretched, and it's never the same after that. It doesn't go to the same length. So it's always stretched out. So there's always going to be a bit of more movement in that joint, more inversion. If it's really bad, the ankle's really unstable. So here's some guidelines, because your patient's going to say, how long is it going to take me to get back to play football or play hockey or whatever it is? So you go, well, these are the guidelines. Some people can go back faster. Some people takes longer. If it's taking really long, there's something going on. There's a hidden injury, or it's more severe than you may have thought. It might be a complete rupture when you thought it was a partial, or there's some kind of chronic synovitis or something going on that's slowing you down. These are just the typical guidelines, yeah? So the grade 3s, they've often got something else going on, a bone problem, a high sprain, or something like that. And when you sprain your ankle badly, you're at double the risk to re-sprain it for 12 months. So you need to protect that ankle for 12 months. After 12 months, the research shows that the risk then goes back to normal. So you're increased for 12 months. That's why a lot of professional athletes preventatively tape their ankles or they brace their ankles, and some of you already know about that. So in basketball, the whole team gets taped. Some of them wear braces or braces as well. When I graduated and I worked for a football team, it was like a tape-a-thon. Like everyone, all the players would come and they'd all get taped one by one. And does anyone here work as a sports trainer and do that? So you get pretty good at it. It's really good practice. The taping that you do for prevention is not the same as the taping you do for rehab, though. There's a difference because you have to allow for swelling. You have to allow for swelling when you're taping an injured ankle. Alright, so here's what the swollen ones look like. The first thing you see with a sprained ankle is an egg over the lateral malleolus. That's the ATFL that's been torn, yeah? You might have swelling higher up, you might have swelling all over. If you've got swelling on both sides, you're looking at a more severe injury. It means it's inverted so far that it's impacted the medial side, and you get bony bruising on the medial side from a massive inversion. And often people, when they're recovering, they've got more pain on the medial side than the lateral side because they've got a bone bruise on the medial side. So that's really common as well. Alright, if you're drinking after the game and you sprained your ankle, it's going to swell a lot more. Is that a question?
Yeah.
Yeah?
Do you take the swelling location as any indication of the injury itself, or do you sort of just go by more the mechanism? Because swelling
it's everything together, but definitely if you've got the one that is, the person who sprained their ankle in front of your eyes because you're at the side of watching the game, and they come in, you see the egg over the lateral malleolus, you're going, okay, that's at least a ruptured ATFL. So yes. But then this is the swelling you see after 2 or 3 days. It's swollen all over, you can't really tell. Then it's about the mechanism, and then it's about palpation and the rest of the things, when you assess the ankle. The bruising comes 2 or 3 days later. The swelling and the bruising is not necessarily an indication of severity. Sometimes a grade 3 is hardly even swollen. It's a complete rupture, it's not even swollen. Sometimes it doesn't even hurt. Why is that?
You've broken the nose as well?
Yeah, you rupture it like you snap your Achilles, which we'll talk about later on. It doesn't even hurt. The person walking in and going, oh, there's something wrong with my ankle. I'm not sure what it is, but they actually don't hurt because all the nerves are torn. The swelling is what happens after the injury, how they've managed it or not managed it. And if they've gone and had a few, had some drinks or whatever, bang, the ankle swells up huge, and you're in it's a lot more difficult. So you really need to control the swelling, get the swelling down, get rid of the swelling. It's bleeding. You don't want blood sort of clotting around the area of the injury. You want to get it away, up the leg. So the first 2 days are the rest, the ice, compression, elevation, some careful massage of getting the swelling and edema. So the swelling and edema are away. You want to disperse it, get rid of it as quickly as possible so the ankle can get going and get the ankle to move. All right, the Ottawa ankle rules. You still need to manage, even if it's a fracture, you still got to manage the acute injury. You got to ice it. Yeah. This is a cryo cuff, or this other thing called there's a game ready thing, which is basically a cuff you put around the ankle, and you pump ice water into that cuff under pressure. It's very effective for the broad, swollen ankle. And you see this at the side of the football field, or the side of the court, where you've got the cryo cuff on the knee or the ankle. Or this other thing called a game ready, which is it's another pump. It's got a pumping action in it. Protection, rest. Protection means don't injure it any worse than it already is. Right? So you tell that person, back off. Don't go out tonight. Stay home. Put your leg up. Elevate. Rest. Ice compression. Elevate. And refer for X-ray. We'll talk about that in a minute. They may need to be non-weight bearing. they can't stand on it or walk on it, that's one of the indications for an X-ray. But they probably should be on crutches. They shouldn't be trying to limp around on it or walk around on it. Limping around on it doesn't do it any good. Limping is not beneficial ever. So you either on crutches, so you have a non-weight bearing or partial weight bearing, or walk normal, have a normal gait pattern. You don't want to develop a limp because they can be very hard to get rid of. You can dunk the foot in a bucket of ice water if you want to. What I do is put the foot in cold water and put the ice in gradually. It's a little bit more kind than just putting it straight into the ice water. And you leave it in there, move the foot up and down in the ice, in the water, take it out, elevate it. Okay, here are the rules. If there's bone tenderness on the posterior edge of the tibia or the tip of the medial malleolus, if there's bone tenderness, which means when you put your thumb on there, that person jumps off the bed. So literally, they jump. That means it's really point tender there. The distal 6 centimetre of the posterior edge of the fibula or the tip of the lateral malleolus, or they can't bear weight, they can't stand up, they can't take 4 steps. They're the 3 criteria. If they're positive on any one of those, they need to go and have an ankle X-ray. 15% of ankle injuries, according to this research, which is pretty old, but I think it's still accurate, have a fracture. Okay, so that's the dark grey areas, the back of the lateral malleolus, or the back of the fibula, the back of the medial malleolus, the back of the tibia. The foot one is, if they're tender in there's rules for the foot as well. Okay, there's bone tenderness at the base of the 5th metatarsal, bone tenderness over the navicular bone. And the same thing, they can't stand on it, they can't walk. They should have their foot X-rays. Right? You can look up the Ottawa rules. If you work in ED, that's going to be your mantra because you're going to see thousands of ankle and foot injuries. Okay, then you're going to make a diagnosis, what grade it is, make a treatment plan. The prognosis depends on who the patient is. Are they a young, fit, full-time professional athlete versus they're an elderly person? All they really need to do is to be able to walk. They don't need to run, jump, pivot or anything on the ankle. So the prognosis depends on that as well, and the plan depends on that. Who's the patient and what are their needs in the rehab, yeah? There's always a two-edged sword. You're trying to go for healing and you're trying to go for function. If it's a first-time injury, that person has never injured their ankle before, and they're a young person, you might opt to try and get healing, because you might want to get an optimum healing result rather than quick function, because that, like I said, if you go for quick function, the price to be paid is sometimes for long pain and maybe instability after that. It's their age, they actually need their ankle to earn their living, and therefore their recovery is really priority number 1 is the quickest recovery possible, and they don't care what happens to their ankle after that, because they've got a career that's only going to go for 5, 6 years or whatever it's going to be. If they've got usually there's something coming up for that person, right? They're going to play the next week, they're going to do the Tough Mudder or whatever it is in 2 weeks' time, they're going to run a marathon or do something coming up, they want to run a race. So that affects your plan. So you've got a timing around that. And then whether it's a chronic problem, if it's really chronic, you're not going to immobilise that person. You're going to go for early function, like get them going, because there's nothing to heal anymore. There's nothing to worry about in terms of trying to immobilise and get early optimal healing. So you're just going to get them going, and as long as they can function, you sort of move on. Now the hidden injuries I talked about, the talar dome, avulsions, fractures. Your Ottawa ankle rules first and start rehabilitating the ankle. If they're not responding in the expected way, they should be able to walk. After a week or 2 weeks, they should be able to weight bear on the ankle and walk. If they can't walk, there's something wrong. Maybe a hidden injury. Alright, the RICE, limit and reduce swelling and the pain. The thing is, it's going to be stiff to move, so the movement is restricted. What's the most important movement to get back first? To walk. No, dorsiflexion. You need dorsiflexion to walk. You need about... How much dorsiflexion is there in the ankle?
50.
Depends on the person.
15? No, less. It's not very much. How much do you reckon? 20, that's better. 20 to 30 degrees. And when you sprain your ankle, you pretty much lose all of it. And then you can't walk because you can't, go past the stance phase and get into the push-off. So people start to walk like that. They turn their foot out. That's bad. Don't let them do that. So you want to restore the dorsiflexion mobility straight away, as soon as you can. Now, this sounds weird, but you actually put them in a heel raise. You put them in a heel, put 2 heel raises in, one under each heel so they're even. And you are putting them into plantar flexion, but what you're actually doing is giving them more movement forward so they can walk with their feet straight. You've got to protect the ankle while you're doing that. Be careful, because if you put a heel raise in, you're putting them in plantar flexion, a little bit of plantar flexion. So that's a little trick you can do to get people walking early. You know what? You put them in a boot. Put them in a moon boot. Have you seen the moon boots? Do you know what they are? Who's been in a moon boot? Hands up. You've been in a moon boot. It allows you to walk when you've got an injury. And I think they should be used more. I think they should be used more for ankle sprains, and I use them now a lot. It's not really, it's a bit, moon boots are more for stress fractures or other things. But you can use them for ankle sprains, they work really well. So you get people walking, they can walk straight, they don't walk with a limp when they're in a boot. Or they might, if they can't weight bear due to severe pain, well, they could have a fracture, or they have to go non-weight bearing. You don't want them non-weight bearing for too long. If there's no fracture to worry about, you want them walking, like weight bearing and walking. So you put them partial weight bearing between 2 crutches, or put them in a boot. That's what I recommend, so people can walk. Okay, consider the use of a moon boot, and then you've got to start giving them their movement. So one of the first things we do after the rest, ice compression, elevation, is do some passive mobilisation of the ankle into dorsiflexion. Dorsiflexion, not plantar flexion. Plantar flexion is one of the mechanisms of injury. That's the way they stretch their ankle. So you don't push that in the beginning. You push dorsiflexion. Get them walking. Get the leg up. The ankle has to be higher than the body, higher than the heart, to reduce swelling. Yeah? Put it up high. Put it up on a chair or pillow so it's up high. Start with passive. We'll do in the prac probably passive to active dorsiflexion, range of motion before plantar flexion. Yeah? We're talking in the case of inversion. If it's eversion, it's not exactly the same, but it's still dorsiflexion is number 1, eversion number 2, then you start to do a bit of plantar flexion, and finally inversion. That's the last movement. Right, so you avoid combined plantar flexion and inversion because that was the mechanism of injury. Does that make sense? Yeah. All right. Passive movement for active. Gait. You want to stop them from developing a limp, because if they develop a limp over 2 or 3 weeks, it's very difficult to get them out of the limp. And the limp is one of the reasons biomechanically someone can get chronic synovitis and problems with their ankle. And they might want to take anti-inflammatories. There's some evidence that says you should avoid anti-inflammatories for the first 48 hours and just take painkillers like paracetamol, and after that you can use the anti-inflammatories. But if there's not a big inflammatory component to their problem, they don't need anti-inflammatories. They might need analgesics if they're in pain and they can't sleep. But usually after a few days after an ankle sprain, they don't need to take anything. They just need to do the rehab. If their ankle is sore, it's because they've been walking around on it too much. They need to rest it, put it up in the air and ice it. Okay, then you can start to stretch the calf with a towel carefully, and then you can start to do some standing lunges carefully. So your weight-bearing dorsiflexion. You've got to do balance. When you injure the ligaments of the ankle, we talked about tearing nerves and damaging the nerves. You compromise the proprioception around the ankle. So those nerves are the things that give you proprioception. So your balance is always affected. Your balance is always damaged. And your balance is always compromised after a sprained ankle. And poor balance is one of the reasons why ankles become chronic, that they sprain over and over again. So you start retraining balance. It doesn't come back by itself. None of these things come back on its own. So practice balancing. Stand on that leg. Stand on the leg with your eyes closed. Later on, you're going to challenge their balance. They stand on a rocker board, a wobble board, foam pads, different things, yeah? Then you've got to, the thing with that balance, it's a feed forward mechanism, which means you have to be prepared for the foot landing on the ground because you don't have time to react. Once the foot lands on the ground, if it's going to give way, your muscles actually don't have time to control that. So the proprioception is feed forward, not feed back. We'll talk about that a bit more another day, but it's old school thinking to think that you can land on your foot and correct it with your muscles. You can't. It's too late. By the time you've landed, the ankle's already in inversion, bang, it's going to go. So this is about, it's skill, and it's the way you teach exercises is you teach people preparation for foot landing rather than correction after they land. Heel and toe, so dorsiflexion, plantar flexion. Now you start off with straight movement, sagittal movement, dorsiflexion, yeah? And your exercises are in a straight line. And then you gradually introduce sideways. So circles, in and out, you draw the alphabet with your foot. And being aware that plantar flexion and inversion is your mechanism of injury. But you do have to restore all the movements, not just dorsiflexion. And follow it with ice. Ice it, tape it, control the swelling with a Tubigrip bandage. You know what a Tubigrip bandage is? It's like a sock. That's a compressive sock. Control the swelling. Progress to full protected weight bearing. Yeah, get them walking off crutches as soon as possible. Work. Okay, at 2 to 4 weeks, more movement, more walking. Get them on an exercise bike with the foot just flat on the pedal, not clipped in, just flat on the pedal. Get them moving, yeah? Aim for full range of motion, and the sequence, like what I said before, dorsiflexion first, then a bit of eversion, get the perineal muscles working, yeah? Then start the plantar flexion and the inversion last. Get the calf going, get the soleus going. The soleus, poor old soleus gets forgotten. Right? Your calf raises, bent leg calf raises to get the soleus going, closer to the ankle. Introduce resisted eversion to get the perineal muscles working. And return, now you're in the zone where you're going to be returning to activity for most people. Return to work or return to sport. Depends on the grade, depends on their rate of recovery. You've got to protect it. Taping is the best way to protect it in the early stages. You can tailor-make the tape job to control the weakness and control the swelling. A brace is okay, but you can't tailor-make a brace, and it's usually not as controlling on the ankle as a really good tape job. So taping in the beginning, a brace goes after. If they're in a boot, you're home free because they're completely protected. But they can't stay in a boot forever. You've got to come out of the boot and you might switch to taping, yeah? Watch out for the skin. When you're taping the skin, it will react. Everyone's skin will react eventually because the adhesive is very acidic on the skin. The adhesive is zinc oxide, which is the same stuff that is used in sunscreens. So if people are allergic to sunscreens, they're automatically allergic to tape. That's one thing you can ask. They might not know. Are you allergic to sunscreens? Oh yeah, I get a rash. So you can be allergic to tape as well. So you have to use hypo tape or underneath layers of tape to protect the skin. After a few days, everybody's skin will react. It starts to go red. Some people like hyperreact, and it goes red and swollen, and they get a full-on allergic reaction. But most people, the skin just goes a bit red. Be careful taking the tape off. It comes off more easily if it's wet. Don't rip it off. Just peel it off. Yeah.
How does those weight players work? I just feel like they constantly take off every week and stuff, and nothing really happens to them. Is it just because they're used to it, or?
Maybe, or they've got skin that doesn't react. But you can help protect the skin. You shave it, and the acidity you can neutralise it with calamine lotion or Mylanta is the secret stuff. Mylanta is an antacid, so you can put that on the skin as well. So yeah, you might be lucky and have no reaction, but a lot of people will react to tape, particularly if they're injured. There's something about it. I don't know, some autonomic response going on, and people will really rash up with the taping. You have to watch out for it, because sometimes the tape rash becomes a bigger problem than the ankle sprain. Watch out for the difficult non-responding ankle. You could have a hip injury. So at that 2 to 4 week mark, if they're not walking freely, there's something sort of weird going on, yeah? All right, the 4 to 6 week mark, most people should be returning to full functions or full sport. So you still need to protect it. Remember what I said? Twice the risk for 12 months. So you've got to protect it with taping or bracing. Practice the skills, the running, the jumping, yeah? Harder balance drills, landing, sticking the landing, yeah? Like the gymnasts you've been watching, they stick the landing because they're prepared for the landing, yeah? Except for that poor guy who broke his leg. Now, running drills, changing direction, figure eights, circles, running in a box, like in a square, cutting, pivoting. So they're all the return to sports skills that you can give that person skill drills to do. Yeah? So I said, the evidence points to feed forward rather than feed back. So it's like you're thinking about what position your ankle is as it's in midair, not when it hits the ground. Okay, the chronic one, they've got ongoing pain, swelling, stiffness, even after 6 weeks, there's something going on. They've got either a chronic instability, a hidden fracture, a chronic synovitis. So that needs further investigation, a diagnosis and a plan around that. Now, if an ankle gets in this thing of functional instability where it's giving way all the time for no real reason, that ankle's very, very unstable. You can try to rehabilitate, late rehabilitation and strengthen it, do all the balance training, all the feed forward, but it still might give way just because the ligaments are all gone. Yeah, that person can have an operation called an ankle reconstruction, where the orthopedic surgeon actually takes tissue from other parts, like take a tendon or other parts of the capsule or ligaments, and create new ligaments on the lateral side of the ankle. But that's like a knee reconstruction. Like it's a big operation, and it's a several, 5-6 month recovery from that. But that's in the situation of an ankle that's just giving way all the time for no good reason, for no real reason, yeah? Apart from the fact that it's unstable. All right, so let's move on to ankle fractures. So we're talking about distal tibia and fibula, yeah? Not proximal. So down lower. And you can have fractures down there. It's all about the malleoli. The medial and lateral malleolas are the things that get fractured. Because they're the things that stick down, and cross the ankle joint. So when your ankle twists or gets pushed sideways, they're the things that break. They can be simple, isolated and undisplaced, and you just whack them in a cast, it's going to heal. And the physio part of it happens at the diagnosis end, and then when they come out of the cast. Not much can happen really while they're in the cast. They can train the rest of their body, but basically you're waiting for the bone to heal. Displaced fractures, that means that the fracture line is open, so it's not a hairline crack. And if it's open or displaced and the bones have separated, it's much more the healing is much more tenuous. It's not going to naturally heal. It needs to be put back in an anatomical position so it will heal properly. And complex so that reduction of the fracture space can be done under local anaesthetic or under surgery, under general anaesthetic. You know, so complex, comminuted, all these difficult fractures that are displaced or they've got instability, they need orthopaedic specialist referral. So if you're working in ED, you're going to see a complex ankle fracture. You're going to bring in the orthopaedic consultant and they'll sort of decide what to do with that one. But the simple ones, the undisplaced ones, only one bone fractured, hairline fracture, you know, pretty straightforward, and nowadays can be handled by the physiotherapist in ED. So that's an open reduction and internal fixation, right? That's surgery for a comminuted and complex fracture on both sides of the ankle. So there's a screw there to put the medial malleolus back in place on the medial side, and a plate and screws over the fibula to put the fibula back together on the lateral side. You'll see lots of those. We get involved after the recovery and after those bones have healed, they've been in a cast or they've been on crutches or whatever, and then they're allowed to start functionally mobilising. That's where physiotherapy gets involved. Now we won't go through a lot of detail here, but there's lots of classifications of ankle fractures, and we'll skip some of it. But it's about how many of the bones are fractured? Bimalleolar, so the medial malleolus and lateral malleolus. Trimalleolar. The back of the talus gets called the third malleolus. So the back lip of the talus is your third malleolus. And if it's a trimalleolar fracture, they're shocking and they always lead to ankle instability. By definition, that fracture has gone through the joint. Yeah? And any fractures that go through the joint, there's a danger that first of all, that they won't heal. But in the long term, osteoarthritis of the ankle. So they're severe and they need an orthopaedic referral. And usually that person has to have surgery for a trimalleolar fracture. That's a simple one, just a hairline crack. You can check it in weight bearing or non-weight bearing. If it doesn't displace, it's very simple. You can put those in a back slab or just a simple cast or even a boot, and they're going to heal. In a young person, it'll heal in 3 weeks and without any complications. So the more complicated ones can be classified as Weber A, B or C, and it's about where the fracture is in relation to the top of the talus there. And the simple one, the Weber A, is the one I just talked about. Put in a cast, it'll heal. The Weber B, the fracture may extend more proximally. It's usually a spiral fracture into the, and these are fractures of the fibula primarily. So you're getting spiral fractures up the fibula and a splitting of the syndesmosis. Then you get as the injury progresses, you get injury on the medial side as well. The medial ligament may be torn, and you see that on an X-ray. On a plain X-ray, if the space between the medial malleolus and the talus is wider, that could be that the medial ligament is torn. Okay, with the conservative management, they get pain relief. You can use ice before you put them in the cast. Put them in the cast, splint, keep them non-weight bearing, ice and elevate for the first few days. Alright, when you put somebody on crutches, you've got to teach them how to use the crutches. A lot of people people fall over the same day that you give them the crutches. They go home and they fall over. They either give themselves a second injury or they make their injury worse. So a lot of the skill of the physiotherapist in this context is putting somebody safely on the crutches so they don't fall over. Right? I can't emphasise that enough. So you're to teach people how to use crutches properly. Who's been on crutches? A lot of you must have been. Yeah, and fallen over on them. I've got a friend who's a physiotherapist. We were playing tennis. I hit a fantastic shot and he fell over. He said, yeah, but see, and then he fell over. And we didn't know. We thought he sprained his ankle. Later on, he actually fractured 2 bones in his foot. He went on the crutches and he went back to work after a couple of days and he fell down the stairs at work and broke his thumb. And he had to stay home from work anyway. He's a very good friend of mine, man. I always remind him of that story. So teach people safely how to negotiate stairs, how to get in and out of chairs and things like that. They're going to fall over. If you don't teach them properly, they're going to fall over. Okay, it's good if a family member is present to help you and to understand what's going on with the crutches. Conservative management, most GPs or physios in ED can handle those ones, the small avulsion ones. It's the bimalleolar, trimalleolar and the instabilities, they need surgery. Usually they need referral and they need surgery. Alright, so that's a boot and there's some walking cast and a fiberglass cast, yeah? So they look like if you haven't seen them before. Okay, then when they come out of their plaster or their boot or wherever they are, that's where our role really kicks in. When they come out, they're going to be stiff, painful to move, and the muscles will be withered away, so they'll be atrophied. So it's our job to get them going and get them functioning again. The bottom line on this slide, really important. When somebody comes out of plaster, their ankle is going to swell up. So you need to go back to the whole thing of elevation in the initial stages. When the cast comes off, they've got to watch out for that early swelling, because that can be a real barrier to progress. And finishing up on fractures, let's go to plantar fasciitis. That's pain underneath the heel bone, not the heel itself, underneath it, yeah? At the origin of the plantar fascia. Okay, there's a lot of traction there where the plantar fascia is pulled on its origin. There's so much traction there that most people develop a bone spur there. The spur is a sign that there's been traction, but the spur is not the injury. The injury is to the soft tissue, the plantar fascia origin. So the heel spur you see on X-ray is an incidental finding. Okay, what it is, it's also called policeman's heel. It's because policemen used to walk around on their feet and in pretty hard shoes on hard surfaces. The worst thing about plantar fasciitis, who's had it? Yeah? What's the worst time? First thing in the morning. When you first stand up and put pressure on that arch, you often tear it a little bit again. You damage it again. So that's the worst pain. That's one of the diagnostic signs is the morning stiffness and pain. When the heel first contacts the ground, they limp and they hobble. And then as they walk a little bit, it warms up a bit. So that's a characteristic of soft tissue injury versus bone. There's a slide on this later on. But the pain behaviour tells you whether it's soft tissue versus bone. There's a lot of stress fractures in the foot. The pain behaviour will be opposite. So in the morning, the stress fracture is fine. You don't even know you've got it. You stand up, you walk around, and off you go. As you more and more weight bearing, the pain of bone gets worse, but the pain of soft tissue often gets better. That's a very important separation that you need to understand and get your diagnostic skills, get your head around that. So the management, there's all kinds of management for plantar fasciitis because it's so common.